Hello friends, this is Dr. Rajiv Dhawan and welcome to this ENT rapid fire round. And this rapid fire round is designed to highlight the main important high yield area of your notes. One humble reminder before we start the session: such kind of rapid reviews or rapid revisions or rapid fire rounds cannot replace the usual classroom text-based, book-based, or the video app-based proper understanding of the subject. Okay. But these sessions are meant to highlight those part of your notes which are more commonly asked in the exams or in your viva, or wherever you go for theory or anything. Such things, if you are very sure about, if you are very confident about, you will be able to answer the question correctly. Okay, so without wasting any time, let us start the rapid fire round of ENT. And I would ask all of you to be in a very high zeal, high enthusiasm kind of mode, and when I speak, you also speak with me, so that the revision is done, so that the things are reinforced in your brain. So first content or topic I want to touch in this rapid fire is the 4 Q's in the ear. There are 4 Q's in the ear which are asked in the MCQs. Number 1 is presbyacusis, and that is age-related sensory neural hearing loss. Number 2, diploacusis means patient hears same sound in 2 frequencies, and that is seen in Menial disease. Hyperacusis means patient gets intolerant to loud sounds, and that is seen in Bell's palsy. It is due to loss of stapedial reflex. And fourth, paracusis villi, which means patient hears better in noisy surroundings, and that's a feature of otosclerosis. So let's once again revise. Presbyacusis is age-related SNHL, diploacusis is a feature of Meniere's, hyperacusis is seen in Bell's palsy, and paracusis villi is a feature of otosclerosis. These 4 are very important questions for your exam. Now, 4 thyroplasty surgeries of larynx. There are 4 thyroplasties. Let's revise all of them. Type 1 thyroplasty is medialization of vocal cord. It is done in adductor palsy, ADD, adductor palsy. Type 2 is lateralization, and that is done in abductor palsy, ABD. Type 3 is shortening or loosening of vocal cord. It is done for puberphonia. Okay. And type 4 is lengthening or tightening of vocal cord, and that is done in androphonia. If you see carefully, type 1 and type 2 are reverse of each other, and type 3 and type 4 are reverse of each other in the procedure also, and in the indication also. Let us once again revise. Type 1 thyroplasty is medialization done for adductor palsy of vocal cord. Type 2 is lateralization of vocal cord done for abductor palsy of vocal cord. Type 3 is shortening or loosening of vocal cord done for puberphonia, and type 4 is lengthening or tightening of vocal cord done for androphonia. Okay, all of you are speaking with me. Try to utilize the session to revise, actually, not to just passively go through the video. That's not the aim. You should speak with me as I speak. So once again, type 1 medialization, type 2 lateralization, type 3 is shortening, loosening, and type 4 is lengthening or tightening of vocal cord. Type 1 is done in adductor palsy, type 2 is done in abductor palsy, type 3 is done in puberphonia, and type 4 is done in androphonia. Look at the screen right now. There are 8 multiple choice questions right now on the screen for you. Can you understand how high yield these sessions can be? Okay. Now, 4 maneuvers in ENT. Okay, all of them are asked in the question in somewhere like that. The first maneuver, Gutsman maneuver, is used in puberphonia. What is puberphonia? Puberphonia means a male patient speaking like a female, means high pitch voice in an adult male. Normal pitch voice in adult male is low pitch, but high pitch voice in adult male is a disease called puberphonia, and the treatment of choice of puberphonia is speech therapy. And for speech therapy, we do a maneuver called Gutsman's maneuver. So Gutsman maneuver is used for puberphonia. Okay. Now Heimlich maneuver, this is used for foreign body aspiration in the larynx. Some food particle has got stuck in the larynx. The typical history will be given in the question as patient is having food, suddenly patient gets choking and aphonia. It means the foreign body has got stuck in the larynx, and for this the immediate treatment will be Heimlich maneuver. Heimlich maneuver, look at the screen. The pressure is given on the epigastrium in backward and upward direction. Heimlich maneuver, pressure is given on the epigastrium in backward and upward direction. Okay. Now, Dick-Solpike maneuver, visual question. Look at the screen better. This is a diagnostic test of BPPV. What is BPPV? Benign paroxysmal positional vertigo. Okay. In Dix-Hallpike maneuver, we make the patient sit down and then we suddenly bring the head down. Patient gets suddenly vertigo and there is nystagmus in the eye, and that is Dix-Hallpike maneuver. It's a diagnostic test of BPPV. Okay. Now, what is the treatment of BPPV? The treatment of BPPV is Apley's maneuver, EPLEY, Apley's maneuver. Apley's maneuver is the treatment of BPPV. In Apley maneuver, we have got 5 positions, from sitting to lying down, turning the head, turning the whole body, then again sitting up. Okay, so if you have got 5 images like this in rotation given in the exam, the visual question, that is Apley's maneuver, and that's treatment of BPPV. But if you are given 2 images like this, you know, one sitting, one lying down, it's a Dix-Hallpike maneuver, diagnostic test of BPPV. Okay, let's revise once again all the 4 maneuver in ENT used. Now, number 1, Gertzmann maneuver is used for puberphonia. Hamlich maneuver is used for foreign body aspiration in the larynx. The Dix-Hallpike maneuver is the diagnostic test of BPPV. Apley's maneuver is the treatment of BPPV. Now, 3 triads of ENT, triad of a triad. All of them are clinical questions. You know, all are true for this triad except. So very possible question. 3 triads. What are 3 famous triads in ENT? Number 1, Semter's triad, the triad of allergy. Semter's triad, allergy to aspirin or NSAIDs. Number 2, asthma. Number 3, nasal polyp. Okay. Once again, Semter's triad is allergy triad. Allergy to aspirin. Due to allergy, there is asthma. Due to allergy, there is nasal polyp. Okay. So Semter's triad, speak with me, beta. Allergy to aspirin. Number 2, bronchial asthma. Number 3, nasal polyp. Okay. Now, number 2, Trotter's triad. Trotter's triad is seen in nasopharyngeal carcinoma. Trotter's triad is seen in nasopharyngeal carcinoma. What is the abbreviation of nasopharyngeal carcinoma? NPC. Look at the Trotter's triad. The 3 features of the Trotter's triad also start from NPC. What is NPC? Nasopharyngeal carcinoma. The mnemonic of Trotter triad is also NPC. Beta. What is N? Neuralgia in temporoparietal area due to 5th nerve involvement. Number 2, palatal paralysis due to 10th nerve involvement. And number 3, conductive hearing loss, which is unilateral. Once again, Trotter's triad is seen in NPC. What is NPC? Nasopharyngeal carcinoma. What is the mnemonic of Trotter's triad? Again, NPC. What is N? Neuralgia in temporoparietal area. P, palatal paralysis. C, conductive hearing loss unilateral due to glue ear. Okay. The third triad, the triad of Gradinego syndrome, which is seen in petrositis beta. Okay. So Gradinego syndrome is seen in petrositis. What are 3 features? Number 1, ear discharge. Number 2, retroorbital pain. Number 3, diplopia. Okay. Have you heard about GERD? Gastroesophageal reflux disease. Gradinego syndrome, the mnemonic is GERD. G mane Gradinego syndrome, E mane ear discharge, R mane retroorbital pain, D mane diplopia. Okay, let's once again revise the 3 triad. Semter's triad, allergy. Number 1, allergy to aspirin. Number 2, asthma. Number 3, nasal polyp. Number 2, Trotter's triad is seen in NPC, nasopharyngeal carcinoma. The mnemonic is NPC. N mane neuralgia in temporoparietal area due to 5th nerve involvement. P, palatal palsy. And C, conductive hearing loss, which is unilateral, which is due to glue ear. Third one is Gradinego syndrome, which is seen in petrositis. The abbreviation, the mnemonic is GERD. G mane Gradinego syndrome, E mane ear discharge, R mane retroorbital pain, and D mane diplopia. Okay. Now, 8 important radiology points of ENT for your exam, for your viva, for your multiple choice questions. You should know it, these 8 points for ENT radiology. Number 1, steeple sign. Steeple sign is seen in acute laryngotracheobronchitis, which is also called as croup, C-R-O-U-P, croup. Okay, and this is narrowing of the subglottic area. Steeple sign is seen in acute laryngotracheobronchitis, also called as croup. Look at the white arrow. There is narrowing of the subglottic area. Okay. One more important question which is also asked: which is the narrowest part of pediatric larynx? The answer is subglottis. Okay. So what is subglottis? You know, which is a ring-like cartilage. Cricoid is the ring-like cartilage. The space in the cricoid ring is called subglottis, and the narrowest part of pediatric larynx is subglottis. Can you tell me what is Adam's apple? Adam's apple is prominence of thyroid cartilage in males. Prominence of thyroid cartilage in males is called Adam's apple. And what is the narrowest part of pediatric larynx? Subglottis, bache. Okay. Now thumb sign, radiology continues. But thumb sign is a feature of acute epiglottitis. Acute epiglottitis means infection of supraglottis area, and the epiglottis gets swollen. It looks like a thumb. Look at the yellow arrows, beta. The epiglottis is looking like a swollen, structure which resembles a thumb. So thumb sign or thumbprint sign, it is a feature of acute epiglottitis. And one more information, acute epiglottitis is an airway emergency in children. The most common causative organism of acute epiglottitis nowadays is Streptococcus pyogenes. Second common cause is H. influenzae B. The most fundamental, the first treatment of acute epiglottitis baby is airway management. Never forget airway management by intubation, because acute epiglottitis is a pediatric airway emergency. So the first treatment is airway management. Okay. Now next one, Hallman-Miller sign on CT scan is a feature of angiofibroma, and this is, look at the red arrow, this is the anterior bowing of posterior wall of maxilla. So in angiofibroma on CT scan we see Hallman-Miller sign, which is also called as antral sign, ANTRAL. Hallman-Miller sign, also called as antral sign. It is a feature of angiofibroma. It is the anterior bowing of posterior wall of maxilla. Okay. Now teardrop sign or teardrop opacity is seen in blowout fracture of the orbit. In the floor of the orbit get fractured. Look at the the CT scan. Out of the floor fracture, there is orbital content prolapsing into the maxillary sinus as if a tear is going to fall in the maxillary sinus, and this is called teardrop sign or teardrop opacity. It's a feature of blowout fracture of the orbit, which is the fracture of the orbital floor. Okay. Now delta sign is a feature of sigmoid sinus thrombosis, also called as lateral sinus thrombosis, and it is seen on CT scan. Okay, fine. Now widening of prevertebral shadow, this is a feature of acute retropharyngeal abscess. Look at the screen, beta. In front of the cervical spine vertebra, there is a big white shadow. This is widening of prevertebral shadow. This is a typical feature of acute retropharyngeal abscess. Okay. Now nasal trauma and X-ray. There is a history of nasal trauma. There is swelling or there is no swelling, but there is a deformity of the nose. And if you move the nasal bone, there is sound called crepitus. There is a field called crepitus over there. So history will be trauma followed by nasal deformity. There may be crepitus. When you move the bone right left, there is a sound like the sensation of the bone rubbing, actually crepitus. If you do the X-ray, look at the X-ray, there's a nasal bone fracture. Look at the white arrow, there's a nasal bone fracture. So this question can come as a story. The patient had trauma, there is a nasal deformity, and the patient has got X-ray finding given in the picture of the MCQ. And what would you opt for the treatment? Guys, the treatment of choice of the nasal bone fracture is immediate fracture reduction before edema starts. This is done using Walsham forceps. But if edema is already present, if the question is given like that, the patient came after 2 days, there is swelling there. If swelling is also mentioned over there, then you wait for 7 days and then reduce the fracture, because let the edema subside. So nasal bone fracture can generate two type of question. If it is immediate fracture, there is no swelling given, no edema given, then the treatment is immediate fracture reduction using Walsham forceps. But if the question says there is also swelling or edema, because patient has come after 2 days, there is swelling around the nose, so then the answer will be wait for 7 days and then reduce the fracture after the edema has subsided. Okay. Now next question, what is the most commonly done or the best X-ray view for paranasal sinuses? The answer is Waters view. Look at the screen. The Waters view is the best X-ray view for sinuses. This is done with open mouth. It shows all the sinuses except posterior ethmoid. Once again, the best X-ray view for paranasal sinuses is Waters view. This is done with open mouth. It shows all sinuses except posterior ethmoid. Okay. Now let's go further. Two mirrors used in ENT OPD. There are two mirrors. You can get a visual question. Look at the screen. There are two mirrors used in ENT OPD. One is called indirect laryngoscopy mirror and second is called posterior rhinoscopy mirror. How to differentiate indirect laryngoscopy mirror, from posterior rhinoscopy mirror, very easy. Indirect laryngoscopy mirror is a straight mirror, but posterior rhinoscopy mirror is an angulated mirror. So straight mirror is IL mirror and angulated mirror is PR mirror, means posterior rhinoscopy mirror. Now very famous question, which structures are not visible on indirect laryngoscopy? So structures not seen, not visible on indirect laryngoscopy. Let's revise once again. Number 1, anterior commissure of vocal cords. Number 2, laryngeal surface or undersurface of epiglottis. Number 3, undersurface of vocal cord. Number 4, adjoining area of subglottis. Number 5, ventricle and saccule. And number 6, apex of piriform sinus. Once again, very important question. Structures which are not visible on indirect laryngoscopy are, let's revise once again, speaker with me beta. Number 1, anterior commissure of vocal cords. Number 2, laryngeal surface or undersurface of epiglottis. Number 3, undersurface of vocal cord. Number 4, an adjoining area of subglottis. Number 5, ventricle and saccule. And number 6, apex of piriform sinus. Okay, now 2 instruments which can be asked from you in the exam by giving image over there. One of this is very commonly used in ENT OPD. This is called lax tongue depressor. You know it's tongue depressor, it's made of steel, but you should know the complete name is lax, lax, L for lac, L for L shape. Can you see it is L shape, beta? Tongue depressor, steel, tongue depressor, steel, L shape, L for lac also. So from the shape you'll remember lax tongue depressor. Another question that will be asked from you in the exam is, there is a retractor used in the ear surgery called Mollison's self-retaining mastoid retractor. Look at screen, beta. What is the name of this retractor? Mollison's self-retaining mastoid retractor. It is used for ear surgeries like mastoidectomy, laryngoplasty, etc. Okay. So once again, beta, what is the name of the tongue depressor? Lax tongue depressor. What is the name of the retractor? Mollison's self-retaining mastoid retractor. Okay. Now, 2 dips in the audiometry. What is the other name of audiometry? PTA. What is PTA? Pure tone audiometry. Also called as audiogram. Audiometry, audiogram, pure tone audiometry are used as synonymous terms in the exam. Beta. Okay. So what are the 2 famous dips in audiogram or audiometry? Number 1 dip is seen in otosclerosis, and this dip is seen at 2000 Hz in bone conduction curve, and this is called Carhart's notch. So Carhart's notch, a very, very important question. Carhart's notch is seen in audiometry in a patient of otosclerosis, and this is dip at 2000 Hz in bone conduction curve. Okay, look at screen, beta. Can you see on the screen the upper line? The upper line shows a dip at 2000 Hz, and this dip, look at the upper line, the dip at 2000 Hz, this dip is called Carhart's notch, and this is seen in otosclerosis. Beta. Once again, the second dip now, noise induced hearing loss. Beta. That shows dip at 4000 Hz in ACBC, and that is called acoustic dip. Okay, so noise induced hearing loss, the dip is called acoustic dip, and this dip is at 2000 Hz in air conduction and bone conduction curve. Beta. Look at screen, beta. Look at the 4000 Hz, written 4000. At 4000, both lines are dipping down. Actually, there's a dip at, look at the 4000, that both lines are dipping down. This is called acoustic dip. Once again, let's revise 2 dips in ENT. Beta. In audiometry, Carhart's notch is a dip seen in otosclerosis. It is dip at 2000 Hz in bone conduction. Okay. Second one, acoustic dip is seen in noise induced hearing loss. It's a dip at 4000 Hz in air conduction and bone conduction. Now the next one, there are 2 special audiograms which you can get in the exam also, beta. Just as a maybe a visual question, maybe as a write up, or maybe as a multiple choice question, one of the choices, beta. Now please see, there are 2 diseases, presbyacusis, age-related SNHL, and Meniere's. Now please understand, this table is important for the exam. Presbyacusis is due to age-related SNHL, that will be bilateral. But Meniere's disease is mostly unilateral. Do remember this point, beta. Meniere's is mostly unilateral. Presbyacusis, age-related, age will damage both ears. Now, so presbyacusis is bilateral, Meniere's is unilateral. Number 2. Presbyacusis mostly causes high frequency SNHL in early stages, high frequency sensory neural hearing loss in early stages. But Meniere's disease causes low frequency SNHL in early stages. Therefore, the audiogram, the audiometry curve is different in the 2 diseases. In presbyacusis, it is sloping curve. In Meniere disease, it is a rising curve. Let us once again revise this table, beta. Presbycusis is age-related SNHL. It is mostly bilateral. It causes high-frequency SNHL. Therefore, it causes sloping curve on audiogram. So, sloping audiogram beta. And Menial disease is mostly unilateral. It causes low-frequency SNHL in early stages, and therefore it causes rising curve in audiogram beta. Okay. So this is the Menial disease rising curve. And this is the presbycusis sloping curve beta. Can you see Menial disease rising curve and presbycusis sloping curve beta? Okay, fine. We have discussed this in length in the class actually. Okay, now 5 drainage point question beta. Very important. Nose has got drainage of multiple things. Let's revise quickly one by one beta. Now, nasolacrimal duct drains into inferior meatus. Okay. Number 2, maxillary sinus, frontal sinus, anterior ethmoid air cell drain into middle meatus. Okay. Now, posterior ethmoid air cell drain into superior meatus. Then sphenoid sinus drain into sphenoethmoidal recess. Okay. And lastly, the surgical opening of DCR mane dacryocystorhinostomy is made in the middle meatus. The surgical opening of DCR is made in the middle meatus. This is ophthalmology surgery of DCR. What is DCR? Dacryocystorhinostomy. Dacryocystorhinostomy. Okay. Let us revise once again. Let us revise once again the 5 drainage points in the nose. Number 1, nasolacrimal duct drain into inferior meatus. Number 2, maxillary sinus, frontal sinus, anterior ethmoid air cell drain into middle meatus. Number 3, posterior ethmoid air cell drain into superior meatus. And number 4, sphenoid sinus drain into sphenoethmoidal recess. And last ophtha question, surgical opening of DCR. What is DCR? Dacryocystorhinostomy is made into the middle meatus. I hope you're speaking with me. That's the whole purpose of the class. You already read all this in your classes, in your notes. We have discussed this multiple number of times in the class also. The idea is you should speak with me so that this gets really, totally reconsolidated in your brain, so that on exam day you are able to recall it very, very surely and very, very easily. Better. Okay. That's the whole purpose of such sessions. Better. Okay. Now, these sessions are not, meant to teach subject. They are meant to highlight what is most probably going to be asked. The chances of these things are going to be asked are higher than the other things. Okay. Now, 5 ethmoid air cell is a fundamentally important question. Beta. What are the 5 ethmoid air cell? Beta? 5 ethmoid air cells which you should know. Number 1, bulla ethmoidalis is the most constant and largest anterior ethmoid air cell. I repeat, bulla ethmoidalis is the most constant and largest anterior ethmoid air cell. Agar nazai is anterior most anterior ethmoid air cell. Agar nazai anterior most anterior ethmoid air cell. Agar AGGE आगे सबसे आगे anterior most माने सबसे आगे most anterior आगे AGGE आगे agar nazai is most anterior. Okay. Heller cell is actually seen in the orbital floor. Onodi cell is seen close to the optic nerve. Concha bullosa is seen inside the middle turbinate. Okay. Bulla ethmoidalis and agar nazai are seen in everyone. Rest 3 cells are variation. They may be seen in some people. Once again, let's revise. Bulla ethmoidalis is the most constant and largest anterior ethmoid air cell. Agar nazai is anterior most anterior ethmoid air cell. Heller cell lies in the orbital floor. Onodi cell lies close to the optic nerve, and concha bullosa lies inside middle turbinate. Okay, let's go further. Important ENT topics which can be, asked. Certain things about them. What are they? This is very important topic. Vocal nodule, also called as singer's nodule, screamer nodule, or teacher nodule. Okay, vocal nodule, also called as singer nodule, screamer nodule, or teacher nodule. It is due to vocal abuse. It is mostly bilateral. It is seen at the junction of anterior 1/3 and posterior 2/3. What is the chief complaint of any vocal cord problem? Hoarse voice. Okay, and treatment of vocal nodule is voice rest or speech therapy. No surgery, voice rest or speech therapy. Once again, vocal nodule, what is the other name of vocal nodule? Singer nodule, screamer nodule, teacher nodule. Unilateral, bilateral? Bilateral. What is site? Junction of anterior 1/3 and posterior 2/3. What is the chief complaint? Hoarse voice. What is the treatment? Speech therapy or voice rest. Next one. Next topic is Laryngo Malaysia. Very important topic. Very important topic. Laryngo Malaysia is the most common congenital anomaly of the larynx. Okay, it is weakness of supraglottis. Supraglottis, beta. Weakness supraglottis, beta. Do you remember what is the classical appearance of the larynx picture? Omega shaped epiglottis is a feature of Laryngo Malaysia. Okay, and what is the classical symptom? Stridor. There is noisy breathing. Stridor. What are the 4 features of stridor? Number 1, it is inspiratory stridor. Number 2, it appears in first week of life. Number 3, it increases on crying. Number 4, it decreases in prone position. Okay, and second point is cry of the baby sound is normal and treatment is conservative. Only reassurance to parents that it is self-limiting condition. Once again, beta, Laryngo Malaysia is congenital anomaly. Examination shows omega shaped epiglottis, beta. The chief complaint is stridor. There are 4 features of stridor. Number 1, it is inspiratory stridor. Number 2, it appears in first week of life. Number 3, it increases on crying. And number 4, very important, it decreases in prone position. But the cry sound of the baby is normal because vocal cords are normal. Because Laryngo Malaysia is a weakness of supraglottis. Okay, and treatment is conservative. Don't forget that omega shaped epiglottis is a feature of Laryngo Malaysia. One more question. Turban epiglottis, TB larynx, beta. Omega epiglottis, Laryngo Malaysia. But turban epiglottis and mouse nibbled appearance of vocal cord are feature of TB larynx, beta. Once again, 2 signs of TB larynx: turban epiglottis. Number 2, mouse nibbled appearance of vocal cord, beta. Okay. Main point. Now let's go to another disease, the CSF Rhinorrhea. Very important topic. CSF Rhinorrhea, one thing, this is a visual question. Target sign or hello sign is a feature of traumatic CSF Rhinorrhea. Not every CSF Rhinorrhea, because traumatic CSF Rhinorrhea is a blood mixed CSF. So if you get this visual question, what is the name of the sign? Target sign or hello sign. It's a feature of traumatic CSF Rhinorrhea. Not any CSF Rhinorrhea. Not every CSF Rhinorrhea, only traumatic CSF Rhinorrhea, bache. Okay. Now, what are the important points to be remembered about CSF Rhinorrhea, beta? First of all, what is the most common site overall? Cribriform plate. Okay. What is the best diagnostic test of CSF Rhinorrhea? Is beta 2 transferrin estimation. What investigation you do to find the site of leak? This is important for exam. How would you find the site of leak? There are investigations like number 1, nasal endoscopy. Number 2, HRCT skull base. Number 3, MRI T2 weighted images. Number 4, CT cysternography. And number 5, 5% fluorescein intrathecal injection. This is a possible question to be asked again, beta. And treatment is conservative treatment, beta. Let us once again revise. CSF Rhinorrhea, overall most common site, cribriform plate. Best confirmatory test is beta 2 transferrin estimation. Then what are the investigation we do to find the site of CSF leak? There are 5 to remember. Number 1, nasal endoscopy. Number 2, HRCT skull base. Number 3, MRI T2 weighted images. Number 4, CT cysternography. And number 5, 5% fluorescein intrathecal injection, beta. If they ask you which is the best investigation for radiology, answer is HRCT skull base. High resolution CT skull base is the best radiological investigation to find the site of CSF leak. What is the treatment of CSF Rhinorrhea? No surgery, beta. The treatment is conservative treatment because a lot of leaks, stop on their own. Very important topic, CSF Rhinorrhea. Next topic, Menial disease. Another important topic, beta. Let's revise. Menial disease is unilateral disease, beta. Mostly unilateral. Episodic disease. Episode has 3 features, beta. Which are 3 features of Menials? Number 1, tinnitus. Number 2, hearing loss. Number 3, vertigo. Okay, tinnitus, hearing loss, vertigo. Tinnitus, hearing loss, vertigo are 3 features of Menials, beta. Then there are very interesting multiple choice question in this, beta. The patient has got recruitment phenomenon. What is recruitment phenomenon? Patient hear loud sound as more loud. Patient has Tullius phenomenon, which means that patient get vertigo on hearing loud sound. Therefore, point number 4, patient has got dislike for noisy area. Okay. Then patient has got low frequency SNHL in early stages and therefore rising curve. Again, diploacusis, we did in Q-sis also. Diploacusis, double sound, feature of Menials, beta. Patient got fluctuating hearing loss and diagnostic investigation is electrocochleography. Menial is a gold mine of multiple choice question. Let's revise once again. Menial is mostly unilateral. Menial is episodic disease. It has got three features. Number one, tinnitus, hearing loss, vertigo. Patient has got recruitment phenomenon, which means patient hear loud sound as more loud. Then Tullio's phenomenon. Patient gets vertigo on hearing loud sound, is called Tullio's phenomenon. Therefore, number 4 point, patient has got dislike for noisy area. Next point, beta. Patient has got low frequency SNHL in early stages, therefore rising curve in audiogram, beta. Diplocusis, bache, double sound, Menial disease, fluctuating hearing loss, it's episodic disease, fluctuating hearing loss, and electrocochleography is a special investigation used to diagnose Menial disease, beta. Very important topic. Please do revise Menial properly from your notes. Glue ear, again a very important topic for your all exam, beta. Serous otitis media or secretory otitis media. Okay, there are two causes of this you need to remember. In children, it is adenoid hypertrophy. In adult, it is nasopharyngeal carcinoma. I repeat, glue ear can be asked from you in two clinical scenarios. In children, glue ear is due to adenoid hypertrophy. In adult, it is due to nasopharyngeal carcinoma, and both of them are causing eustachian tube blockage, and eustachian tube, has got function of ventilating the middle ear, and this eustachian tube blockage causes disease called glue ear or serous otitis media. Okay, once again, glue ear can be asked from you in two scenarios. In children, due to adenoid hypertrophy. In adult, due to nasopharyngeal carcinoma, and both of them cause what? Eustachian tube blockage. Okay, now in glue ear there is conductive hearing loss. Okay, and the treatment is of course maryngotomy. You give incision on the tympanic membrane. And in which quadrant you do maryngotomy in glue ear? Maryngotomy in glue ear is done in antero-inferior quadrant. But in ASOM, acute suppurative otitis media, we do maryngotomy in posterior-inferior quadrant. There are two maryngotomy questions. In glue ear, the maryngotomy is done in antero-inferior quadrant. In the ASOM, acute suppurative otitis media, the maryngotomy is done in posterior-inferior quadrant. And glue mange grommet. Remember the class, beta? Glue needs grommet. Glue, G for glue, G for grommet. After doing maryngotomy, you put what? Grommet. Grommet is a dumbbell-shaped small tube, and grommet is put in the tympanic membrane, and the grommet is also called middle ear ventilation tube. Beta. Middle ear ventilation tube. Okay. So G for glue, G for grommet. Glue needs grommet, beta. In not every maryngotomy needs grommet. Glue needs grommet. G for glue, G for grommet, beta. Okay. Once again, glue ear is also called as serous otitis media. There are two causes. In children, it is due to adenoid hypertrophy. In adult, it is due to nasopharyngeal carcinoma. And the treatment is maryngotomy in antero-inferior quadrant, followed by grommet insertion. And grommet is also called as middle ear ventilation tube. Okay, one anatomy question, beta. Guys, which muscle opens the eustachian tube during swallowing? The answer is tensor villi palatini. Tensor villi palatini or tensor palati muscle is same thing. Tensor villi palatini or tensor palati muscle is the muscle responsible for opening the eustachian tube during swallowing. Is anatomy ENT question. Remember, which muscle opens the eustachian tube? Tensor villi palatini, also called as tensor palati muscle. Okay. Now Quincy, very important question. Quincy, look at this clinical visual question. The uvula is angulated, the tonsil is pushed medially, beta. Okay. Remember, Quincy has got two classical symptoms given in the question. One, trismus. What is trismus? Difficulty in mouth opening. And trismus is due to spasm of medial pterygoid muscle. Okay. And number two, plummy voice or hot potato voice, beta. Okay. Plummy voice or hot potato voice. So patient having throat pain, trismus, plummy voice or hot potato voice, with the picture given in the image right now. Look at the uvula is angulated. Whenever uvula is angulated and tonsil is pushed medially, think of Quincy, beta. Quincy. Okay. Do not confuse. Quincy is peritonsillar abscess. It's an abscess. Do not confuse Quincy with another word starting with Q called Quincke disease. Quincke disease is isolated idiopathic angineurotic edema of uvula. Okay, it is actually edema of uvula due to unknown reason or due to angineurotic edema actually. Okay, I repeat, beta. Quincy is peritonsillar abscess. In this, uvula is angulated, tonsil is pushed medially. But in Quincke disease, there is edema of the uvula only, beta. These two are overlapping terms, but they are different, beta. Quincy, Quincy, don't confuse, beta. Quincy, Quincy, don't confuse. Am I clear? Fine. Now, diphtheria membrane for pediatric question, beta. Child may be given the history with fever, toxemic picture, bull neck, bilateral lymph nodes in the neck. With this kind of picture given in the supportive, images, the diphtheria gives whitish membrane in the tonsil area, but the membrane extends beyond tonsil to the palate actually. The typical picture of diphtheria membrane, which is a whitish membrane on tonsil, the classical picture is that diphtheria white membrane extends beyond tonsil to palate. In the history of the patient in pediatric question, the child will be toxemic, fever, bull neck due to bilateral cervical lymphadenopathy, and this picture may be given additionally to support the diagnosis of diphtheria. Okay, now Ludwigs angina. Don't think every angina is cardiac, beta. This is actually the infection of submandibular space or floor of mouth. Infection of submandibular space or floor of mouth. It is basically due to dental infection. And what is the causative organism of Ludwig's angina? MCQ microbiology. What is the causative organism? Is the mixed bacteria, streptococci plus anaerobes. Once again, Ludwig's angina is infection of floor of mouth, chin area, floor of mouth, also called as submandibular space. The typical history will be after an episode of dental caries or dental infection, patient develop chin swelling and trismus. What is trismus? Difficulty in mouth opening. What is the cause of Ludwig's angina? Dental infection. What is the bacteria responsible? Streptococci plus anaerobes. Okay, now another visual question for dermatology also. The most common malignancy of the skin of the external nose is basal cell carcinoma or rodent ulcer, beta. Okay, this is a very, very commonly asked derma question also. The rodent ulcer has got, rolled out edges with the telangiectatic, margins over there. There are some blood vessels over there, beta. So basal cell carcinoma, also called a rodent ulcer, it is the most common malignancy of the skin of the external nose. This can be a visual question for you in derma or ENT. Okay, how to identify that? The ulcer with rolled out edges with telangiectatic, margins over there. Telangiectasia means the blood vessel are there, it's visible over there. Pott's puffy tumor, very, very common question. Pott's puffy tumor is the, frontal osteomyelitis or subperiosteofrontal abscess due to frontal sinusitis. So frontal sinusitis lead to frontal osteomyelitis, which can lead to subperiosteofrontal abscess, and this subperiosteal frontal abscess is actually Pott's puffy tumor. It's not a tumor, it is actually the frontal bone infection. So Pott's puffy tumor is not a tumor, it's a frontal bone infection which is basically due to frontal sinusitis, which gets complicated as frontal osteomyelitis, which further leads to this final picture, which is called subperiosteal frontal abscess, also called as Pott's puffy tumor. One more tumor in ENT, Ringett's tumor, Ringertz. Ringett's tumor is actually other name of inverted papilloma of nose. Important topic. Inverted papilloma of nose is called Ringett's tumor, but Pott's puffy tumor is osteomyelitis of frontal bone or subperiosteofrontal abscess. Mucormycosis, very, very possible, in the COVID era is a very possible question. Mucormycosis, it is due to the, mucor fungi. It is seen in 3 group of patients: HIV positive patient, patient on immunosuppressive drug, a young diabetic patient, and number 4 now COVID-19 positive patient. Okay, so I repeat, mucormycosis can be asked in 4 group of patients: HIV positive patient, patient on immunosuppressive drugs, young diabetic patient, and number 4 COVID-19 patient on steroid therapy. Okay, the classical picture of mucormycosis is black because this fungus blocks the blood vessels. Okay, and the classical sign on MRI of the sinuses is black turbinate sign. Black is a hallmark, black turbinate sign on MRI also. And the drug of choice is liposomal amphotericin B plus debridement also. Now don't forget, it's not only the medicine, debridement also, dead tissue. Can you see the black dead tissue? Debridement also, followed by drug of choice amphotericin B, particularly liposomal amphotericin B. So mucormycosis is a very possible question now. Black color bit over there. Okay, now diabetes and ENT generate 2 questions. Let me tell you, diabetes can be asked in 2 questions in ENT. Young diabetic, nose question, blackish mass in the nose, mucormycosis is the answer. Old diabetic, ear question, some pain in the ear, the answer is malignant otitis externa. Once again, young diabetic, nose question, Black color, mucormycosis is the answer. Okay, and the drug of choice is liposomal amphotericin B. But old diabetic, ear question, pain in the ear. The answer is diagnosis is malignant otitis externa, which is caused by Pseudomonas, and the drug of choice is third generation cephalosporin. Once again, young diabetic nose question, mucormycosis. Old diabetic ear question, malignant otitis externa, which is due to Pseudomonas. Okay, just remember like that. It's a rapid fire actually. Okay. Septal hematoma, very possible clinical vignette based question. Patient get history of trauma. There is a bilateral nasal swelling. There is bilateral nasal blockage. The treatment of septal hematoma is immediate aspiration or drainage. Beta. Okay, septal hematoma story form question. Beta. There is history of trauma followed by edema of the nose followed by the bilateral nasal blockage. The key word is septal hematoma. Look at the screen. It is mostly bilateral, and the treatment is immediate aspiration or drainage. Beta. So septal hematoma, trauma history, bilateral nasal blockage after trauma. It is septal hematoma diagnosis, and treatment is aspiration or drainage. Beta. Next one, boxer ear or cauliflower ear. It is the post-traumatic deformity of pinna. After trauma, the cartilage gets necrosed due to hematoma, and the shape of the pinna gets spoiled, and this post-traumatic deformity of pinna we've seen in boxers commonly. That's why it's called boxer ear or cauliflower ear. Once again, what is boxer ear or cauliflower ear? It is post-traumatic deformity of pinna. Okay, fine. Next one, Darwin tubercle. Look at the pinna. Darwin tubercle is not a disease. It's an anatomical variation. Darwin tubercle is an anatomical variation. It's a conical elevation on helix only. It's a conical elevation on helix only. Beta. Am I clear? So Darwin's tubercle is a conical elevation on helix. It's not a disease. It's anatomical variation. Bat ear. Bat ear is absence of antihelix. It's a cosmetic problem. It's a disease. The surgery for the plastic reconstruction of pinna is done at 6 years of age. Multiple choice question. The plastic reconstruction of pinna is done at 6 years of age, because by that time pinna almost gains full size. Beta. Am I clear? Beta? Fine. Once again, beta, boxer ear or cauliflower ear is the post-traumatic deformity of pinna. Darwin tubercle is not a disease, is anatomical variation. It's a conical elevation on helix. Bat ear is absence of antihelix. It's a cosmetic disease. The plastic reconstruction is done at 6 years of age. Next one, traumatic rupture of eardrum, classical question in clinical story base. Patient has the matchstick, damages the eardrum, there's a hole over there. Can you see what is the treatment of choice of traumatic rupture of eardrum? The answer is conservative treatment. Don't give laryngoplasty, don't put eardrop, no antibiotic, nothing, no painkiller, nothing. Just keep the ear dry. Remember, this is a very possible question. Traumatic rupture of eardrum, what is the best management? The answer is just keep the ear dry. That is conservative management. No surgery, no eardrop. I repeat, traumatic perforation, traumatic rupture of eardrum, what is the treatment of choice? Conservative treatment, in the bracket, just keep the ear dry. The nature will heal on its own. What is this being done? Ear syringing, which is done for wax removal. What is the direction of water in ear syringing? The answer is posterior superior, beta. Posterior superior, okay? And never use cold water because it can lead to vertigo. Once again, two questions of syringing. Syringing direction of water is posterior superior. Never use cold water because it can lead to vertigo. Okay, bache? One more question like this, beta. Patient cannot smell anything. There is anosmia. No smell, cannot smell tea, coffee, asafoetida, hing. No. Which agent patient can smell? Ammonia. Ammonia. Because ammonia is not a smell. Ammonia is an irritant. It is sensed through trigeminal nerve. Okay. So ear syringing, two question. Direction of water, posterior superior. Never use cold water because it can lead to vertigo. Second, anosmia patient can smell ammonia. Ammonia is not a smell. It's an irritant sensed through trigeminal nerve. Ammonia sensed through trigeminal nerve. Okay. Bera. Look at this can be a visual question. Bera. Look at this child can be given like that, and they're going to ask you what test is being done. Bera. What is full form Bera? Brainstem evoked response audiometry. Bera. Brainstem evoked response audiometry. How many waves Bera has? 7 waves. Which is the most important wave of Bera? Wave 5. Wave 5 beta. And wave 5 is produced by lateral lemniscus beta. Once again, what is full form of Bera? Brainstem evoked response audiometry. Okay, how many waves Bara has? 7 waves. Which is the most important wave in Bara? Wave 5. Wave 5 of Bara is produced by lateral lemniscus. Next one. Ongral line. Visual question beta. Ongral line. It is the line from medial canthus to angle of mandible. Speak up with me beta. Speak up bache. Ongral line is from medial canthus to angle of mandible. Okay. It is used for which cancer? It is used for cancer of maxillary sinus. It is used to calculate the prognosis. Any cancer above this line has poor prognosis due to early orbital involvement. Once again, Ongral line is from medial canthus to the angle of mandible. Visual question also. It is used for which cancer? Cancer of maxillary sinus. It is used for what? For surgery? No. It is used to assess the prognosis. Any cancer above this line has poor prognosis due to early orbital involvement. So this can be a visual question also. Ongral line. Never forget that. Ongral line from medial canthus to angle of mandible. Now again a visual question. Modified Young operation. But anytime they show you some needle stitching the entry point of the nose, think about the modified Young's operation done for atrophic rhinitis. So modified Young operation is done for which disease? Atrophic rhinitis. It is the partial closure of the both nostrils. Once again, anytime they show you somebody stitching right at the entry of the nose, which surgery is being done? Modified Young's operation, because we don't do Young nowadays actually. So modified Young operation is what? It is done for which disease? Atrophic rhinitis. It is what beta? It is partial closure of both nostrils. Remember, atrophic rhinitis has got what? Merciful anosmia. Patient has got bad smell from herself, but patient cannot smell anything. So merciful anosmia is a feature of atrophic rhinitis. Atrophic rhinitis uses what? Alkaline nasal douching powder to wash the nose. Okay, the powder contains 3 things: sodium bicarbonate, sodium biborate, and sodium chloride. Once again, the merciful anosmia is a feature of atrophic rhinitis. The alkaline nasal douching powder used in atrophic rhinitis contains 3 agents. Let us speak with me. Number 1, sodium bicarbonate, sodium biborate, and sodium chloride. Okay, and modified Young operation, Luton-Slager operation are done for the atrophic rhinitis. But this particular picture, when the needle is shown in front of the entry point of the nose, think about the modified Young operation done for atrophic rhinitis. It is the partial closure of both nostrils. Next one, important ENT clinical vignettes. There can be clinical story based things can be asked. Let us revise them. They are a multiple choice question for your exam. Very important question. 28-year-old female with bilateral gradually progressive hearing loss. Young female with bilateral hearing loss, think of otosclerosis. Young female with bilateral hearing loss, think of otosclerosis. Always, otosclerosis is more common in young females. It is mostly bilateral. Okay. Now in otosclerosis, the treatment is surgery. The treatment of choice of otosclerosis is surgery, because in otosclerosis what happens is stapes gets fixed. And the name of surgery is stapedotomy or stapedectomy. In this surgery, we replace the fixed stapes with stapes piston prosthesis. Stapes piston prosthesis. Visual question. Anything like a question mark is stapes piston prosthesis. And one important point about otosclerosis is it's gradually progressive disease. It takes many years to spread further. In the early stage, you see a sign called Schwartz sign. Schwartz sign is seen in early stage of disease. It is flamingo pink appearance behind tympanic membrane, and if Schwartz sign is positive, it means disease has just started. It means disease has got early stage going on right now. So the treatment of choice is not surgery. Then the treatment of choice will change to sodium fluoride therapy, because it's a gradually progressive disease. In the early stage, you give just sodium fluoride. Okay, but please do remember very fundamental MCQ. Pregnancy aggravates otosclerosis. Remember, lady turns pregnant and the hearing loss increases. Which disease is behind the scene actually? Otosclerosis. Once again, let's revise the clinical vignette. 28-year-old female, young female with bilateral gradually progressive conductive hearing loss. The answer is otosclerosis. Otosclerosis is seen in young female. It's mostly bilateral. It's gradually progressive disease. Treatment. What is otosclerosis? Basically, it is fixation of stapes. Remember, treatment is surgery called stapedotomy or stapedectomy. The surgery means that let us replace the fixed stapes with artificial stapes piston prosthesis. Look at the screen. It looks like a question mark. It looks like a question mark. Something like a question mark in the visual question is stapes piston prosthesis. I told you in the early stage, you see a sign called Schwartz sign, and Schwartz sign means flamingo pink appearance behind the tympanic membrane. Schwartz sign indicates the disease is in early stage. If Schwartz sign positive patient is there, the treatment of choice is not surgery. The treatment of choice for Schwartz sign positive patient of otosclerosis is sodium fluoride therapy. And do remember, pregnancy aggravates otosclerosis is a multiple choice question. In otosclerosis, what type of tympanometry curve you see? Tympanometry A, S curve. In glue ear, B curve. In eustachian tube blockage, C curve. In ossicular dislocation, A, D curve. Let's revise 5 curve of tympanometry. Type A curve is seen in normal people. B curve, flat curve, glue ear. A, S curve, otosclerosis. A, D curve, ossicular dislocation. And C curve, eustachian tube blockage. Once again, tympanometry 5 curve. A curve normal, B curve flat curve seen in glue ear, AS curve is seen in otosclerosis, AD curve is seen in ossicular dislocation, and the C curve is seen in eustachian tube blockage. Okay, fine. Next, clinical vignette number 2. 45-year-old female with the pulsatile tinnitus and or bleeding mass in the ear. A lady with pulsatile tinnitus or bleeding ear mass, a lady with something pulsating or bleeding in the ear is glomus jugulae. A lady with, something pulsating or bleeding in the ear is glomus jugulae. Remember that it's a highly vascular tumor. It is causing pulsatile tinnitus, very classical thing. There is a bleeding red ear mass. The red thing is going into the ear. This is called a rising sun sign. Very important question, beta. Rising sun sign is the feature of glomus jugulae. The tumor blanches on sigillization. It's called brown sign. CT scan shows Phelps sign. It is a highly vascular tumor, so avoid the biopsy in this patient. Once again, glomus jugulae is more common in females. It's a highly vascular tumor, therefore it causes pulsatile tinnitus. It grows in the ear as a red bleeding ear mass. Please do remember, this patient will be having the rising sun sign because the red mass is entering the middle ear from below upwards. The red mass blanches on sigillization, and that's called brown sign. CT scan shows Phelps sign. Do not biopsy this tumor because it's a highly vascular tumor. Okay, fine. Now, next question. 12-year-old boy with nasal mass and perfuse epistaxis. Now, young boy with nasal mass and perfuse epistaxis, this is actually angiofibroma. Angiofibroma. Angiofibroma is seen in young adolescent boys in 12 to 14 years of age. It's a highly vascular tumor again of the nasopharynx, which comes to the nose, and therefore the classical presentation is the young boy with nasal mass and perfuse epistaxis. The answer is angiofibroma. There is a typical deformity. Look of the patient is called frog face deformity. It is typical of angiofibroma. Frog face deformity is typical of angiofibroma. Okay, so it means that we have got 2 vascular tumor in ENT. 2 vascular tumor in ENT. One in female, other in male. In female, it is glomus jugulae. In young boys, it is angiofibroma. Both are highly vascular. In both, biopsies contraindicated. Okay, so very easy. A lady with something pulsating or bleeding in ear is glomus jugular question. A young boy with nasal bleeding is angiofibroma question. Very easy. 2 vascular tumor in ENT. Female, glomus jugulae. Male, young male, angiofibroma. A lady with something pulsating, pulsatile tinnitus. A lady with something pulsating or bleeding in the ear is glomus jugular question. And a young boy with nasal bleeding, epistaxis, of course angiofibroma. And angiofibroma gives what? Frog face deformity. And glomus jugular gives what? The rising sun sign. Okay, rising sun sign. Okay. Now, next one. The 50-year-old patient with conductive hearing loss unilateral and cervical lymphadenopathy is a short question of the exam. This is nasopharyngeal carcinoma. This topic should be revised word by word from the notes. It's a very important topic, very, very commonly asked. Each line should be remembered of this topic. Nasopharyngeal carcinoma is typically presenting with unilateral conductive hearing loss due to unilateral glue ear, and the first presentation of this cancer is metastatic cervical lymphadenopathy beta. The first clinical presentation of nasopharyngeal carcinoma is metastatic cervical lymphadenopathy beta. Am I clear bache? Fine. Which virus causes nasopharyngeal carcinoma? Epstein-Barr virus bache. Epstein-Barr virus. What is the site of origin of this cancer? Fossa of Rosenmuller, which lies just above the Eustachian tube opening. Fossa of Rosenmuller lies just above the Eustachian tube opening. This is a visual question beta. Look at the yellow arrow. The yellow arrow is indicating the fossa of Rosenmuller, and just below that you see an opening, and that is the opening of Eustachian tube beta. So what is the site of origin of this cancer? Is fossa of Rosenmuller. Which virus is behind it? Epstein-Barr virus. Nasopharyngeal carcinoma is more common in China, and the treatment of choice of this patient is chemoradiation. If chemoradiation is not given in the choices, then you mark radiotherapy. Best answer, chemoradiation. Second best answer, radiotherapy. Once again, please don't forget even a single word about nasopharyngeal carcinoma. Each word has to be remembered by you. The patient typically has got unilateral conductive hearing loss due to unilateral glue ear. And the most common presentation of nasopharyngeal carcinoma is metastatic cervical lymphadenopathy. It is called by which virus? Epstein-Barr virus, and it is arising from fossa of Rosenmuller. Fossa of Rosenmuller, visual question. This lies just above the Eustachian tube opening, and the treatment of choice is chemoradiation. Second best answer is radiotherapy. Nasopharyngeal carcinoma is damn important topic. Okay. Now another visual question like that. Can you see another? This was a fossa of Rosenmuller just above Eustachian tube opening. If you get a visual question on the side of the larynx, can you see vocal cord? On the side of larynx, can you see yellow arrow? The yellow arrow are indicating the pariform sinus beta, also called pariform fossa. Pariform sinus is same as pariform fossa. Don't get confused beta. So pariform sinus are on right and left side of the larynx beta. If you ever get a question like this, on the side of larynx you're getting some arrows pointing to space. Of course this is pariform sinus beta. Okay, fossa of Rosenmuller is just above Eustachian tube opening, and pariform sinus is on the side of the larynx, on the right side and the left side. There are two pariform sinuses, right and left. Okay, now next clinical story. A long-standing history of foul-smelling, blood-stained ear discharge. If you ever get this question in the exam, a long-standing history of blood-stained, foul-smelling ear discharge, think of unsafe chronic suppurative otitis media. If you remember, unsafe CSOM has got ear discharge, which is foul-smelling and blood-stained. If they make a question like that, unsafe CSOM patient, they want you to diagnose it. The long-standing history of blood-stained, foul-smelling ear discharge. Please do remember, this is typical of unsafe CSOM. I hope you remember, unsafe CSOM is also called as aticoantral CSOM. Aticoantral CSOM. Next, again a possible clinical vignette-based question, clinical story-based question. 7-year-old child with unilateral foul-smelling nasal discharge and epistaxis. A young child with the unilateral foul-smelling nasal discharge and epistaxis. Why unilateral? It's not infection, beta. Infection would have been bilateral. Single side smell, single side pus, single side blood. This is due to foreign body nose, beta. Foreign body nose. The child has put something in the nose and it has been there for last few days, beta. So single side infection, pus, smell and blood from one. The key word is unilateral. A school going child with a single unilateral foul smell and blood coming from single side, that is typical of foreign body in the nose. Okay, now next question. 6-year-old child with chronic hoarseness of voice with mild respiratory difficulty. Now why 6 year? Why this? Think about it. Why clinical vignettes? There are clues over there, hidden clues. Why he is saying particularly 6 years, beta? With chronic hoarseness of voice. This is typical of juvenile papilloma of larynx, beta. Juvenile papilloma of larynx, it is typically seen in 4 to 6 year age child, beta. Juvenile, it is seen in 4 to 6 year age child, beta. Papilloma word will remind me, it is called by human papilloma virus. There are multiple warts on the vocal cord. Can you see HPV warts, beta? So juvenile papilloma of larynx, juvenile word will make me recall it is disease of 4 to 6 year age children, beta. Papilloma word will make me recall it is due to HPV 6 and 11, beta. Am I clear, bache? Fine. Okay, so this is juvenile papilloma of larynx. Once again read, beta. 6-year-old child with chronic hoarseness of voice. You know why? Because these warts will take time to develop, beta. okay, and with mild respiratory difficulty, because they might block the airway also. There may be mild respiratory difficulty. So 4 to 6 year age child with chronic hoarse voice, think of juvenile papilloma of larynx, and is caused by HPV 6 and 11. I hope you remember it is treated with CO2 laser, carbon dioxide laser, but recurrence is very common in the disease, because these viral warts come back. Next one, 40-year-old female patient with brief episode of vertigo on changing head position. When the lady turns head to the right side, she says, I feel vertigo. This is what? BPPV, benign paroxysmal positional vertigo. 5 questions of BPPV, beta. Let's revise. What is full form of BPPV? Benign paroxysmal positional vertigo. What is the cause of BPPV? Displaced otoconia, also called otolith. Otoconia, also called otolith, get displaced. Which canal is most commonly affected in BPPV? Posterior semicircular canal. There is typical chief complaint of, brief episode of vertigo on changing head position. There is no hearing loss, there is no tinnitus, nothing. Only brief episode of vertigo. Doctor, vertigo for few seconds on changing head position, and then I'm all right. What is the diagnostic test of BPPV? Dix-Hallpike test or Dix-Hallpike maneuver. Treatment is Applis maneuver. Once again, benign paroxysmal positional vertigo. This is due to displaced otoconia. Most commonly involved canal is posterior semicircular canal. Chief complaint is vertigo for few seconds on changing head position. Diagnostic test is Dix-Hallpike maneuver, and treatment is Applis maneuver. Am I clear? Now, young patient with roomy nasal cavity and nasal crusting. Roomy cavity with crust formation in the nose. This is typical of atrophic rhinitis. Young patient with the roomy nasal cavity with nasal crusting. This is typical of atrophic rhinitis, also called as ozena. Atrophic rhinitis is also called as ozena. And which bacteria can be behind it? Klebsiella ozene. Beta. So whenever given a young patient with the roomy nasal cavity and nasal crusting, think of atrophic rhinitis. But just be careful. This question can be twisted like this. Beta. Look at screen. Young patient with the roomy nasal cavity, nasal crusting and hard external nose. The previous was young patient with roomy nasal cavity and nasal crusting. That's all. But this question is young patient with the roomy nasal cavity with nasal crusting and hard external nose. The answer is rhinoscleroma or woody nose. Rhinoscleroma or woody nose, beta. Woody nose. Now this is caused by Klebsiella rhinoscleromatis. Klebsiella rhinoscleromatis, beta. Guys, in atrophic rhinitis, ozena, the bacteria name is Klebsiella ozene. But in rhinoscleroma woody nose, the bacteria is Klebsiella rhinoscleromatis. Why there is a confusing picture like atrophic rhinitis? Why? Because the first stage of disease is atrophic stage, which resembles atrophic rhinitis. And the second stage is granulomatous stage, which leads to hard external nose, which is called woody nose. Okay, beta. What is the typical biopsy finding of rhinoscleroma? Rhinoscleroma biopsy finding: Russell bodies and Mycosis cells. Russell bodies and Mycosis cell are typical feature of rhinoscleroma on histopathology. What is drug of choice of rhinoscleroma? The drug of choice is tetracycline plus streptomycin, beta, for 6 weeks. Okay, tetracycline plus streptomycin for 6 weeks. Okay, once again, beta. Young patient with roomy nasal cavity and nasal crusting, only this much, atrophic rhinitis. But young patient with roomy nasal cavity, nasal crusting and hard external nose, then the answer will be rhinoscleroma or woody nose, beta. And the typical histopathology picture is Russell body, Mycosis cell are seen in rhinoscleroma, and drug of choice of rhinoscleroma is tetracycline and streptomycin. This is rhinoscleroma. Anybody, what is rhinophyma? Rhinophyma is potato nose. Also the hypertrophy of the sebaceous glands of the skin of the external nose. Don't confuse rhinoscleroma with rhinophyma. Rhinophyma is potato nose, that is hypertrophy of sebaceous glands of the skin of the external nose. And don't confuse this with the rhinosporidiosis. Look at the rhinoscleroma, woody nose. Rhinophyma, potato nose. And rhinosporidiosis is actually another kind of disease caused by the aquatic protozoa called Rhinosporidium seabrai, which is common in southern part of the country. And there is mulberry-like nasal mass. Look at screen. Mulberry-like nasal mass is typical seen in rhinosporidosis, also sometimes called strawberry-like nasal mass. So mulberry-like nasal mass or strawberry-like nasal mass, this is typical of rhinosporidosis, and the treatment is excision of the mass with the cautery of the base plus Dapsone is the drug of choice. Dapsone is given after surgery to prevent the recurrence better. So once again, rhinosporidiosis is caused by aquatic protozoa, which is more common in southern part of the country. The typical clinical presentation is mulberry-like or strawberry-like nasal mass with epistaxis. The treatment of choice is surgery, in which we do the excision of the mass with the cautery of the base, followed by the Dapsone, which is the drug of choice to prevent recurrence better. Okay, and please do remember, the rhinosporidiosis causes mulberry-like nasal mass. But there's another question on mulberry nose. Mulberry appearance of nasal. So this was just a very ultra rapid fire round, created just to highlight the main important part of your notes once again. And please go through these, the topics once again from your notes quickly, so that you are actually, fresh with this when you land up in your exam actually. Okay. But again, I remind you, that, you have to just make sure one thing, that you have to learn properly. At this juncture, I would like to introduce you to the video lectures I created to make the learning more, appropriate, more interesting, more, a more like classroom kind of, feeling in the video itself, covering the different aspects like, instruments, radiology, the various segment of ENT in a systematic manner. So that I've tried to do in this app also, just to share with you this information on this platform also. Okay. Thank you very much, bache. God bless you, and keep doing, hard work. That is the way to go forward, and that is the only thing which is blessed by the God, beta. God doesn't bless us. God can only choose to bless our hard work. So let us do a lot of hard work, and let us make, our dreams, go, convert into reality. Okay, that's the whole purpose of this. This life is one time opportunity. Let's make the things happen better. Okay, thank you very much. Take care. We'll be again connected soon.